It should be clarified that when talking about pressure or volume-controlled ventilation modes, these are not ventilation modes per se, they do not define or specify a mode, rather, they simply tell us which variable is being controlled during inspiration in the ventilation mode, but not which mode, since both pressure and volume can be controlled in sequences such as CMV or SIMV. In volume-controlled modes, the clinician must set the flow pattern, flow rate, trigger sensitivity, tidal volume, respiratory rate, positive and expiratory pressure, PEEP, and inspired oxygen fraction, FiO2. After endotracheal intubation, physicians first have a choice between two main modes of ventilation, pressure-controlled and volume-controlled. IRV is commonly used for pressure-controlled ventilation, but volume-controlled ventilation can also be performed by using a low flow rate or by introducing an inspiratory pause with each breath. In practice, modern ventilators deliver VCV by controlling inspiratory flow. On other ventilators, both inspiratory time and flow are set. If the inspiratory time is longer than the time required to deliver VT, a terminal inspiratory pause will occur. In pressure control, inspiratory time determines how long the patient will remain at peak pressure. This will create a certain tidal volume. In ventilated patients, inspiratory time depends on tidal volume and inspiratory rate. During PCV, the clinician must titrate the inspiratory pressure to the measured tidal volume, but the inspiratory flow and flow waveform are determined by the ventilator as it attempts to maintain a square inspiratory pressure profile. In addition, pressure-controlled ventilation, PCV, has several advantages over volume-controlled ventilation, VCV, 18, such as the resulting rectangular pressure waveform that provides maximal inspiratory pressure throughout the inspiratory time, facilitating lung recruitment. Compared with volume-controlled ventilation with the rectangular flow waveform, pressure-controlled ventilation and volume-controlled ventilation with a decelerating flow waveform provided better oxygenation at lower peak inspiratory pressures and higher mean airway pressures. The initial ventilation mode of the PCV group was volume control, the same setting as that of volume control ventilation. After CO2 established pneumoperitoneum, it was changed to pressure control ventilation and the inspiratory airway pressure was set and adjusted to provide a tidal volume of 8 ml/kg BMI. In the PCV group, airway pressure was adjusted until a VT of 6 ml/kg was reached and the PCV mode was used for ventilation. Patients were ventilated with a tidal volume of 10 ml/kg. The respiratory rate was set to maintain pH 7.30 and PaCO 250 mm Hg/art, and positive end expiratory pressure, PEEP, was set to maintain PaO 270 mm Hg or SaO2 93% with FiO2 or equals 0.50. The spirometry module recorded peak inspiratory airway pressure, peak, plateau airway pressure, plat, mean airway pressure, mean, dynamic lung compliance, CDYN, and static lung compliance, STAT. PCV by its nature limits the maximum airway pressure delivered to the lungs, but can lead to changes in tidal and minute volumes. With changes in respiratory mechanics, e.g., endurance, compliance, and patient effort, airway pressure changes as the delivered volume remains constant. During pressure-controlled ventilation, volume is a dependent variable and there may be significant changes in VT due to changes in the resistance or compliance of the respiratory system or in the patient's inspiratory effort. A critical difference in pressure control that may explain the difference in tolerability lies in the ability of pressure-controlled ventilation to maintain a constant airway pressure by varying the inspiratory rate according to the needs of the patient. Although pressure control has shown improvement in ventilator timing, some results can be seen on the ventilator display indicating that adjustments are needed to continue to maintain optimal conditions. 3. Both types of ventilation control offer some advantages based on better parameter control in the original PCV modes and better patient adaptation in the case of pressure-controlled modes. Both volume-targeted and pressure-targeted ventilation are used, with the latter being increasingly used. Although no comparative studies are available, The perceived benefit of these approaches is to provide adequate restful breathing when using a stress protocol, which may provide better patient ventilator synchrony. Most mechanical ventilators currently available offer a form of pressure-limited mechanical ventilation that delivers tidal volumes. Excessive pressure can lead to a significant increase in tidal volume, which can lead to volume trauma, or, after an adequate and safe pressure is set, the tidal volume becomes too low for the patient's ideal body weight, leading to increased dead space ventilation, and the opposite occurs. The situation eventually led to ventilation failure. The volume delivered may vary depending on the patient's own breathing capacity, chest compliance, airway resistance, and even other ventilator parameters such as inspiratory/expiratory ratio and ascent time. Average tidal volume delivered in both pressure-limited and volume-limited modes. We used a threshold of 6 ml/kg as the desired target tidal volume and compared it with data from studies that did not achieve this target. Using the term mechanical work, MW, instead of the energy delivered by the ventilator to the respiratory system in one breath, ventilator WAB, MP is MW times respiratory rate, RR, 7. Mode in manually controlled ventilation, the minute ventilation, VE, is determined by the set respiratory rate and tidal volume. We calculated ventilator WAB, which remains a useful parameter of patient WAB during assisted ventilation, when efforts are required to activate and maintain adequate inspiratory flow. Pressure prediction forms the basis of ventilator control theory and recently proposed classifications. The most important discovery of the respiratory system dynamics equation is that any ventilator we can imagine is capable of controlling only one variable at a time during inspiration, pressure, volume, or flow control, but not two variables at the same time. In the new generation of ventilators, the doctor can also set the rise time, that is, the time required to reach the set pressure.